Thank you for giving the opportunity to talk on this topic. Obviously, this is a very controversial topic, and nobody will agree that the intervention radiology will rest in peace. But I am going to show you that what we can do, and sometimes we can do better than the radiologist. How we are going to show you. So advances has been made in intervention pulmonology, like we can have a acquiring larger chunk of tissue. We can do mediastinal staging and restaging in lung cancer and pleural tumors, management of acute hemoptysis, treatment of central airway obstruction, whereas management of intractable malignant pleural effusions also. How? We'll show you. First we come to diagnosis. Let us show this video where we can see that actually when we take this cryobiopsy from endobronchial tissue, we end up in a much bigger chunk of tissue. And then we come how the things are like central and peripheral lesions. There's a central lung cancer, which can only be biopsied by bronchoscopy or digit bronchoscopy. Or sometimes there are tumors which are abutting to the central bronchus. We can do a EBNA, endobronchial needle aspiration. Sometimes there is the way of doing it with a EBUS probe, and doing it with a EBUS probe is actually much safer than any interventional procedure because it's an ultrasound guided real-time procedure. There was a doubt that it was an FNAC and it may not give you the amount of tissue. So that has also been solved when we are doing this mediastinal cryobiopsy. Here we are showing you how this cryobiopsy is done. Here it is, we are going with a EBUS needle. With this EBUS needle, we first make a puncture, put our needle in, and after the puncture is made, we can actually, this is the needle puncture where we are doing the FNAC, and just we can do it with a cryoprobe going to the same aperture that we are going to show you now. So again, if you can put a cryoprobe inside, then actually you are getting much more tissue than any kind of FNAC can do. This is the cryoprobe which can go in the third space. We are learning from the other specialties like this third spacing or going to the third space has first been started in the gastroenterology, and now we are doing it. You can see the cryoprobe within the node and we can take a large chunk of biopsy. Now come to the peripheral pulmonary lesions, which are more suitable for transthoracic needle aspiration or transthoracic needle biopsy till date. But nowadays we are attempting them also. Older literature, the TBLB, transbronchial lung biopsy, the yield is very poor and it doesn't come at all near the percutaneous needle aspiration. But nowadays, the new things have come like guided bronchoscopy. Guided bronchoscopy means you guide your bronchoscope to the lesion by multiple modality. You guide by comparing real time with the CT. You guide by doing repeated X-rays at the same time. So we have this VVN, EMN, BTP, BTPNA, CRM, etc. and cone beam CT. The cone beam CT can ultimately show you this image when you are actually doing the bronchoscopy, and which means you can go to this precision. This is tool in the lesion. You can know whether your tool within the lesion, tool is beyond the lesion, tool is at the side of the lesion. So you can actually know how closely and how perfectly you have sampled it. When it comes to the virtual bronchoscopic navigation, it is actually a CT images obtained and then feed in the software and then it is being compared. EMN, it adds on a platform which can actually compare how your bronchoscope is going along with the previous scan has been made. You can see that two lines, one is green and then one is violet. They basically conclude whether you are going to the same nodule. And the radial EBUS. Radial EBUS is a much available tool. Radial EBUS means you can put your USD scope to the lesion and you can actually image it either concentric or eccentric. If you do a concentric lesion, it looks like this. And we have some videos, but we'll not time to show it. So this is a lesion where we have done a radial EBUS. It looks like this, and the HP comes out to be inflammatory lesion. Later, it comes out to be tuberculosis. This is another lesion. We can also go to it to a radial EBUS, which will come carcinoma. For this lesion in the mid part of the lungs, we again get a papillary and acini cancer. And all these lesions, as we are doing cryobiopsy, we're getting a good amount of tissue. All kind of molecular diagnosis can be possible. And this is a meta-analysis published in 2017, which has shown that our ability to diagnosis is up to 70%. This is obviously less than the uh, percutaneous needle biopsy. But if you look at the complication, then our complication rate, our rate of pneumothorax is much lower when we are going for the peripheral lesion, which is much higher when you are going for the percutaneous biopsies. And this is a new mode, BTPNA, where you can directly go to the lesion through the bronchus with a predefined path. And when everything is combined, we can achieve up to 80% diagnostic yield with a complication rate of less than 5% with all our guided bronchoscopy modes together. Then we have this cryoprobe, which has larger tissue, better tissue preservation, thinner apparatus, and we can reach up to the periphery with this. So it is helpful in endobronchial biopsy. It is possibly helpful in peripheral pulmonary lesion biopsies. You can see the tissues and you can see how better they are maintained. Now, primary mediastinal staging, as it is not the purview of the radiologist, radiological, you cannot reach most of the lymph nodes. So we are not going into details. That is a debate. But it has been shown that EBA staging and the restaging both have mortality benefit in lung cancer patients. And there are the therapeutics where we are definitely ahead of the intervention radiologist. We can clear this airway. We have just cleared one airway yesterday. So this was the look of the airway when we started, and it comes like this when we exit. So we take out the tumor. So here also the IP benefits. We can clear the central airways. This is another photo, and this is a CT where X-ray and the CT where we are showing that the tumor is completely occluding the right main bronchus. And after the stent was done, it improves to this extent. So therapeutically, intervention pulmonology has lots of role in the field of lung cancer. Now, these are new things coming up, like endoluminal brachytherapy, where we help to put the guide wire or the catheter in the proper place so that endoluminal brachytherapy can be done. It has been recommended for various cancers, also for the tracheal cancers. And this fiducial marker placement for the small nodules where surgery can be guided with that markers is also being placed. Bronchoscopic ablative therapies, they're coming on already. CT guided ablative therapies are being used. Our catheter being prepared, and we are also planning after diagnosing a nodule with a radial EBUS, we will put a catheter and ablate the nodule at the same time, at the same go. That can be possible in near future. And we can manage acute hemoptysis. This is a video where we are showing this patient is actually having a massive hemoptysis. When we actually diagnose the site of the hemoptysis at right upper lobe posterior segment, we can actually go into the segment, put a catheter which is known as a glue catheter or sclerotherapist catheter. Within the segment, we can put a 2 ml of glue, and that ultimately result in control of the bleeding. Thank you.
Thank you for a very nice presentation. Let me invite Dr. Lokesh, who is heading the radiology from Apollo, to put his points.
Good afternoon, all. I would like to thank the organizers for inviting me for this debate. As already the pulmonologist has spoken, in the modern era of interventional pulmonology, it's time for the interventional radiologist to rest in peace. And obviously, I'm dead against the motion. So various procedures done by the interventional radiologist. So I actually speaking after seeing the presentation of the pulmonologist, it's only in case of non-vascular interventions, right? So we primarily do a lot of vascular interventions also, and they are all image guided. So we are more accurate with less complications. The procedures we do routinely are biopsies, drainages, chest tube placement and tunnel pleural catheters, bronchial artery embolizations, tumor ablations, radiofrequency ablation, microwave ablation and cryoablations, chemoembolization, chemoport and PICC lines, catheter-directed thrombolysis and mechanical thrombectomy in pulmonary embolism, embolization in pulmonary vascular malformations, thoracic duct embolization for chylothorax. So quickly, I'll go through few cases which we have done in Apollo. The non-vascular ones is a peripheral nodule which is touching the pleura. It's a small nodule We did a CT guided biopsy. Another large lesion, which is abutting the pleura, CT guided biopsy with no complications. This is another lesion. A lesion which is abutting the descending thoracic aorta. And as you can see here, the post biopsy only shows very linear minimal hemorrhage along the needle track. This is left upper lobe lesion with biopsy. Pleural based lesions where the biopsies can be done. Again, peripheral lesion. A large lesion. Important is we usually either do a CCT or we give contrast at the same time to look for areas of necrosis, and we basically target the non-necrotic areas for a better yield. Another case, the other technique we use is known as Pearl, where you have a thin pneumothorax post biopsy. So we make the patient lie down on the same side for some time, and usually it either disappears or there's no increase in the pneumothorax. Catheter drainages for encysted effusions. This is a large pneumothorax, spontaneous because of large bully, you can see, where a catheter placement was done. Iatrogenic pneumothorax done because of a central line, thin pneumothorax. Again, we put in a catheter drain. Pericardial effusion drainages, those which are mostly lateral or posterior are referred to us, wherein we do the drainage either with the needle or with the catheter. Encysted effusion. This was a hemothorax with multiple rib fractures. Lung abscess. So I just wanted to highlight this study which was done by Wang et al. The main two things to see here are basically the comparison between the radial EBUS group and the CT biopsy group. They compared two things, the diagnostic yield and the complications. Yes, the complications in CT guided biopsies were a little higher, but most of them didn't warrant any admissions. But if you go through the diagnostic yields, based on the size, first criteria was the size of the lesion. If it is less than 20 mm for the radial EBUS, the yield is 50%. It increases with the increase in size, but it goes to max 76%. Whereas in CT guided biopsy, it is independent of the size, and usually it is in the mid to high 80%. Second criteria they took was the distance between the nodule or the lesion and the pleura. As you can see again, if the distance is less than 20 mm, the yield in EBUS is 45%, which increases as the distance from the pleura increases from 68 to 77. Whereas in case of CT guided biopsy, again, it is independent. It's again in the high 80s. The third criteria they took was the relationship with great vessels, whether it is near or away. EBUS yield is around 65%, whereas in case of CT guided biopsy, it is in the high 80%. And then important is the location of the probe in EBUS, whether it is within the lesion, then the percentage is 76% yield. But if it is adjacent or they're not able to see, it's less than 50% yield. This is another article which shows the importance of the bronchus sign, which is important for the radial EBUS. If the bronchus sign is present, the yield is pretty good. But if the bronchus sign is absent, that means there is no bronchus which is seen within the lesion, the yield by EBUS is merely 33%. So overall in CT guided biopsies, the accuracy and the yield is about 93.9%. Based on the nodular size, it varies from 83 to 87, 97. And this is the technique of Pearl, which I was talking about for reducing the rate of complications. That's combining the patient positioning, biopsy side down, needle removal during expiration, autologous blood patch sealing, rapid rollover, and pleural patching. Now we go to the vascular cases. I don't think there's any competition in vascular cases as far as the interventional pulmonology is concerned. So this is a case I have borrowed from my radiology colleague, Swabhumi. This was a case of pneumonia with cavitation, which shows a pulmonary artery pseudoaneurysm, which can be very well seen on the CT angio also. So it was selectively catheterized, and you can see that the contrast when injected is going into the bronchus. And so this was embolized by coil. The next few cases I am going to show you were done by my colleague Manas in Apollo. And I borrowed the slides from him. This was a case of hemoptysis. Came to the hospital multiple times to the pulmonologist. They tried with glue insertion endobronchially, but kept coming back repeatedly with hemoptysis. Very minimal, as you can see in the alveolar hemorrhage on CT. So CT angio was done, where you can see multiple bronchial arteries. Some of them or most of them are of normal size. They're not enlarged. So we went ahead and did selective embolization, and they were embolized. I mean, selective catheterization and embolized, and the patient was absolutely fine after bronchial artery embolization. This is another case of a vascular malformation in the lung, as you can see here. Angio, this was a selective catheterization. You can see the lesion. So again, it was selectively catheterized and embolized. You can see the multiple plugs which were used for embolization. Pulmonary thromboembolism, you can see a large thrombus in the left pulmonary artery and the right pulmonary artery. Again, you put in your catheter, can do a thrombolysis, or you can even do a mechanical thrombectomy. This is another case wherein you can see that there are multiple lesions. Most of them were showing calcifications, but one lesion in the right lower lobe was looking suspicious. PET CT was done, and the right lower lobe lesion only showed a very high SUV. So this was taken up, proved to be a CA, and was taken up for radiofrequency ablation. As you can see, the probe within the lesion, and this is the reconstructed sagittal image. You can see that the probe is located centrally within the lesion. This is another case of peripheral lesion which underwent radiofrequency ablation. The misses. So I would like to show you two cases where image guidance was not used for the intervention, and this was not done by the radiologist. So this was a case where a catheter placement was done for right pleural effusion, referred to us for a CT angio to look for a bleeder because there was fresh blood coming through the catheter. CT angio revealed that the catheter was in the interlobar pulmonary artery. So you can see nicely here where the catheter is placed. This is the axial images. So the cardiothoracic team was called upon, and they successfully removed the catheter from the interlobar pulmonary artery. This is another case which was referred for left pleural aspiration. Catheter placement was done, and after that, a drain was put and a thoracoscopic intervention was planned. But again, when they introduced a thoracoscope, they could see a spurt of blood. So we were immediately called for ultrasound. I myself did the ultrasound. We could see a big tear in the spleen. Shifted to CT scan. What we see here is active bleeding and splenic injury. Now here you can see that there is active bleeding in the spleen, and that's the drain, which is basically infradiaphragmatic, and there is a tear in the spleen with active bleeding in the spleen. The patient was taken up immediately and the splenectomy was done. So coming back to the debate, the points which I want to put across to the House is the advanced imaging expertise of interventional radiologists, because IRs are very highly skilled in using CT, ultrasound, fluoroscopy, and MRI for real-time procedures. So it's a greater precision and less complications. Interventional radiologists have a more established training program, which is globally recognized. Pleural procedures are still IR dominated. Chest tube placements and tunnel pleural catheters are done by IRs. Chylothorax treatment is predominantly done by IR, where we do a lymphangiography and thoracic duct embolization. Tumor ablations for lung cancer is led by IR, whether it is radiofrequency ablation or microwave ablation or cryoablation. There is an expanding role of IR in pulmonary oncology. We also assist in vascular access for chemotherapy. Pulmonary embolism management remains an IR specialty, and interventional radiologists handle more complex cases where there is a multi-system disease involvement and where you have to treat multiple organs. Also, the IRs are better trained in advanced catheter-based interventions, giving them an edge in treating pulmonary vascular conditions. In my humble opinion, interventional pulmonology training is still limited. It's growing. It is relatively new, and there are very few trained specialists compared to the IRs. With the advancement of AI, robotics, and image-guided interventions, both IR and IP will continue to evolve without one replacing the other. The interventional pulmonologist and the radiologist.
Dr. Lokesh, we are exceeding time by lot.
Just 2 minutes. IPs and IRs should complement each other rather than compete. And the best patient outcome occurs when the interventional pulmonologist and interventional radiologist work together rather than trying to eliminate the other. So the common points to ponder are: none of the CT-guided interventions, non-vascular, need anesthesia. Time taken is less. It's 5 to 10 minutes. The expertise is more. Location of the lung masses, there's no restriction for CT-guided biopsies. The site selection within the mass, we are much more equipped with that. The cost is, I think, 1/3 or 1/4 as far as the EBUS is concerned. The diagnostic yield is much better. We use 18 gauge and 2 centimeter specimens, at least 2 to 3 we take from each lesion. And the core biopsy size and adequacy is also a factor. So to conclude, the interventional radiologists remain indispensable in the field of pulmonology. The expertise in imaging, vascular interventions, pleural disease management, lung tumor ablation, and pulmonary embolism treatment ensures that they continue to be essential partners alongside interventional pulmonologists. Rather than resting in peace, IRs will continue to evolve and expand their role in pulmonary medicine. Thank you.
Thank you for your presentation. I think this, as a chairperson, what I can say is that both presentations are great. Rather than saying what essence your presentation is that saying rest in peace and replacing one by other, rather than we should work together, which is best. There is no doubt that some procedures are best done by pulmonologists, like all central procedures. And there are some inaccessible lesions which are actually can be done easily by them. Whereas the vascular procedures are domain of IRs. There is no doubt about it. You cannot do anything with those procedures which you have shown. Third, hemoptysis, for which there does intervention and a lot of glues inside the bronchus. These are temporary procedures. For repeated recurrent bleeds, you don't have any option. So I think this topic is a little bit not proper.
Yeah.
Not proper. I would say it was heavily loaded in favor of the IRs because of the vascular
No, sir,
part.
this
Yes.
topic is very important because interventional pulmonology is getting its foots as a specialty or a subspecialty. Recently, it has been approved in US as a specialty training. So we are evolving. So it's a great honor for us if we come in direct controversy with the interventional radiologists that we may replace them. We don't want to replace them. But this is the recognition that we are getting, that we are making us happy, and they making this specialty as a reality. When it is started, I mean 20 years, 25 years back, who have started it, they don't actually expected that they will come to the platform that they are being compared to radiologists, and there is a topic which is saying that interventional radiology may rest in peace with the help of interventional pulmonology. So it's a great honor for us to just discuss on it, just debate on it. There is no point. I know we cannot win. We are not developed to the extent that we can win over interventional radiology. There is no need to win. But this is something good for our specialty. Thank you, sir.
One message to the house is very clear. It is not to win. Interventional pulmonologists don't want to win over IR, but it is a ultimate goal should be our patient should win. So it's a selecting which patient should go to the IR or to the IP. It's a mutual development, and ultimately, if the patient wins, we are winning.
Sir, I want to make one comment. I am Professor Joydeep Deb. I want to share with you that you told about the CT guided procedures and you told about the bronchoscopy guided procedures. But there is one big thing is coming in the way is the ultrasound guided procedures. I think the ultrasound guided procedures may be done by both the pulmonologist and the radiologist. They should be done by pulmonologist, and who could be taken by to the center, radiology center, they can be done by the radiologist. And these USG guided procedures are coming in a big way, where we need a help of both pulmonologists and the radiologists for the benefit of the patients. This is coming in a big way in new days.
Thank you for your point. It's actually a good question, but this is just for presentation. If you go really, 90% of my procedures I do ultrasound guided, and there is no comparison. Those precision cannot be made. When you say ultrasound guided, even mediastinal nodes mediastinal masses, all lung masses which are relatively touching pleura anywhere, all these procedures with all these guided procedures, including all Plurex catheter placement, everything, 90% cases I do ultrasound guided. So that is a very highly precision skilled procedure.
Yeah, it's only
Agree
for the
with you, sir.
presentation that I've shown the CT guided, but most of the procedures in ICUs and ITUs, we do it bedside only, ultrasound guided.
Sir, I agree with both of you, sir. USG guided procedures are the domain of radiologists. Pulmonologists do some procedures in absence of intervention radiologists or when there is an acute emergency. Otherwise, all USG guided procedures are primarily the domain of radiologists, sir. Intervention pulmonology don't enter in this USG guided procedures.
And that's why my last slide said it's a teamwork, right? It's a combination of both the IR and the IPs, because I do get some referrals for reviewing the CT scans for a centrally located mass. I look at it and send it back to the pulmonologist that the biopsy should be done by EBUS because it's centrally located and it's not that we can't do it, but it will be better done by the pulmonologist. So it has to be a teamwork. Whichever they can do better, the patients have to be referred to them back, and which can be done by us, we do it. Thank you.
Thank you very much for this interesting session. We have to conclude now because the next session is coming up.
Thank you, chairpersons and the debaters, for this wonderful debate.